we've kind of shifted gears from some of the basic science and some of the exciting new things that are on the horizon in terms of the treatment of transverse myelitis and multiple sclerosis to some more practical matters about, how do we address issues like temperature irregularity and what I'd like to talk about is how do I look at the evaluation of gait and the use of splints or orthotic devices in the overall thinking about how can we make walking more efficient and comfortable. Some of what I'd like to talk about was covered yesterday by Kathy Zakowski in terms of gait analysis, but I'd like to also present my perspective on kind of how I do it. One thing to think about is, there's multiple causes of abnormal gait, and you can have more than one reason for walking abnormally. And just one of those four things on this slide is the neurological deficit. You can also have pain secondary to the deficit that's causing a change in how you walk and maybe require a change in the kind of footwear that you're using or splints that you're using. Weakness here can be primary, secondary to the neurological deficits, but it can also be secondary, just from not getting as much exercise. And part of the prescription of a rehabilitation plan to work on gait might be exercise. And then structural abnormalities, which are joint deformities that, again, may be secondary to the underlying neurological problem. When I look at someone walk, I find it useful to think about these three functional tasks, and they help me divide out the different things that could be causing a problem, and then also help me think about, well, what are some of the interventions that might be useful? These three things are weight acceptance. What does the patient do when they put their foot down and their body now has to accept their body weight on that single limb? And the things that go into weight acceptance are the way that the ankle primarily articulates with the floor and the leg above it. What kind of movement have you got around that weight-bearing structure? And then as the weight goes on to the weight-bearing limb, how does the body respond? How does the patient respond to weight loading over that foot? The second thing that I look at is single limb support. And what that is when your body shifts over to that weight-bearing side and picks up the other foot to swing it forward, is there any collapsing? Is there any lurching or a change in the center of gravity? And what I tend to look at during this part of the functional analysis of gait would be knee usually. I'm usually looking at the knee to see if there's any buckling at the knee. But of course the other joints could also be involved there too. And then how do they pick up the limb that they're going to now move forward would be part of what I'm looking at during the single limb support phase of watching somebody walk. And then the third thing that I want to know as I'm observing gait is how does the person move their swing limb or advancing limb forward, and that's called swing limb advancement. And the specific things that I'm looking for here is how do they clear their foot? Is it through a compensatory mechanism where they have to hike their hip up or bend their knee? Does the toe get caught as they swing their foot forward? Do they have to swing the foot out and around to make it clear? And then once they get it past the weight-bearing limb, how do they reposition the foot now to take the next step? So with that as sort of the basis, what I'm going to show now is a couple of slides that go through the act of walking divided in more the classic terminology. This is called the stance phase of gait, and what there is to look at here is there's right in the middle of every stride there's something called the period of double support, which is where the heel of one foot and the toe of the other foot are on the ground at the same time. Then look at this leg right here, That's the stance limb. And what you want to look at is the knee to make sure that during mid-stance there's still a forward propulsion of the trunk and the body to move the legs forward. And then there's down here at the foot, there's a period where there's a toe off and terminal toe off. So you want to know, how does this stance limb during the stance phase of gait leave the ground and prepare for the next step where the opposite side starts to bear the weight. So the position of the ankle is something that we look at pretty carefully during gait, and one of the ways to look at ankle position is to divide it into 3 phases. These are called the first rocker. Well, the person that developed this terminology called these rockers first, second, and third rockers, because she was thinking about the foot sort of rocking forward. And the first 2 rockers are deceleration phases of gait, where you're kind of slowing down the forward momentum of the leg and the body so that you can then be stable during mid-stance and then take a controlled toe off during the third rocker phase of gait. And this rocker is an acceleration rather than a deceleration phase of stance as you push yourself forward. So these are all things that are running through our minds as we're trying to analyze what's wrong with a person's gait pattern. And then the next phase would be the swing phase, when you're swinging that leg forward. And here we're interested in what's the interplay of the muscles that extend the leg, the quadriceps, that would be the rectus femoris, and the muscle in back of the thigh, or the hamstring, a muscle that bends the knee but also acts as a brake as you're swinging that leg forward, so that the leg doesn't go shooting forward and there's no control. So the hamstrings are actually a decelerating muscle during the swing phase of gait. And one of the things that we look at here is how far can the individual move that foot forward. So we're very interested in what's the step length, and is it too short or too long, and that gives us some idea of what the balance of muscle activity around the between the rectus femoris and the femoris, and the rectus femoris and the hamstrings. Okay, so that's sort of a quick rundown of sort of how physiatrists look at the gait pattern and gait analysis. What I'd like to just mention now are just some of the critical factors that might impact upon what I call the 3 functional tasks that you do during walking. The first one, getting back to an earlier slide, is weight acceptance. And the critical factors are heel contact first, and controlled knee and ankle motion with hip stability. So we're looking at that very carefully during this phase. Single limb support, the critical factors, again, are control of the movement of your body forward, which means a controlled set of muscle contractions and relaxations that affect how that foot rocks forward from a heel strike to toe off. And to be able to do that in a coordinated fashion, you look at whether the ankle locks in a stable position, whether there's a controlled heel rise, and what happens with the trailing limb as they go to move it forward. And then the third functional phase that we looked at earlier, that I mentioned earlier, was how do you advance the person's swing limb. And some of the critical factors that we look at here are how does the knee respond as it moves forward? Is there a sort of a nice, easy, passive forward swing at the knee, or is it stuck in a certain angle or certain position? What happens around the hips? Can the person slightly bend their hips forward to clear their toes as they're swinging that knee forward? And how much knee extension do you have during the swing phase of gait? Now, since I'm a pediatrician, I put a child in my title here, but this would be true for adults as well. And these are just some principles that I wrote down in terms of treating a patient with a motor disability. And I think one of the answers to the questions in our question and answer session earlier was, let's be clear about what the end product and long-range objective is of treating, of a treatment plan that is going to be talking about prescribing an orthotic device. So clearly define the end product and long-range objectives, and as much as possible, identify the patient's problems with precision. And that might mean, if it's a straightforward problem, having them walk back and forth down the hall with and without their braces multiple times so that you have a good sense of what's going on. But if you're not sure, it could also involve sending that patient to a instrumented gait analysis laboratory. And I think Dr. Sikowski talked about that the other day, where they put markers on the hips, knees, and ankles, and then follow the progression of that individual back and forth along a walkway and feed that information to a computer so that can be analyzed in terms of angles and force vectors at the knees, hips, and ankles. And sometimes when we're planning an orthopedic procedure, that's a critical piece of information that will help the orthopedist decide which muscles to cut and which ones to leave alone, which is very important. Another thing is to, and this is more true in the pediatric group, but is analyze growth effects with and without treatment, and to think about, well, what are things going to look like in a year or 2 years or 3 years, because the effects of the bone of the different relationships of bone length to muscle length and how those joints work are going to change depending on how quickly the child's growing. Consider valid treatment alternatives and treat the whole person. So I think there's a lot of information out there about different kinds of therapies, different kinds of braces. And I think it's important to keep an open mind to other possibilities. And I think that again gets back to analyzing each individual patient's problems. It's a very unique circumstance that each person finds themselves in, and it might turn out that one intervention for this person is not going to be the best intervention for the next person. So. And parents might come, or patients might come to you and say, you know, I read about this. What do you think? And when you read about it, it's a form of exercise, basically. And I get that quite a bit. And as long as I feel that exercise would be beneficial for the patient, and that the modality that's being used by this program, whatever it is, isn't harmful, I usually will say, well, go ahead and try it out. Lesions in transverse myelitis result in, as you all know, increased muscle tone. If those muscles aren't stretched out, you can have muscle contractures that occur during growth or just with inactivity. Loss of selective muscle control. You can have ambulation via reflex patterns and balance difficulties. So given that underlying combination of things that affect someone's walking pattern, the principles of therapy, I think, should be to define the effects of the injury, how much of those 4 different components are making a difference in that person's ability to walk. Develop a practical therapy program, and I put practical in this because I think oftentimes there's this need to do something basically to overdo it. And it's basically something that I think both therapists and sometimes the patients are prone to doing. And what I tell parents is if your therapist gives you a list of 20 different exercises and puts the burden on you or on the patient to pick the ones that they want to do, that's really not a good therapy program. What you need is homework from the therapist that's very specific, and it says, you know, for the next month, let's say 4 weeks, we're going to work on exercise 1, 2, and 3, and I want you to do them these specific ways. This amount of time, these number of repetitions per day. And I think the more specific you can get it, the better your chances are, too, of actually carrying out those programs, because you've got something to kind of keep track of. And, of course, that gets into the third principle of therapy, which is to try to do it as consistently as possible. So if it's not practical, and I found that this is true of my own exercise program. If I work out too much in a couple of days, then I'll take a break for about a month or two. So that's not very useful. So doing it in a practical sense on a consistent basis is going to give you the best result. So let's go through those three areas. Defining the effects of injury on motor function. This is basically a well-done, careful physical and neurological exam where your physician has a way of determining whether the muscle tone or spasticity that's getting in the way of you walking effectively is a spastic form of muscle tone or a dystonic form. Dystonic muscle tone abnormalities would probably be more common with multiple sclerosis or things that would involve the motor centers in the brain, whereas in transverse myelitis, you're going to see more of the spastic kind of muscle tone. Which muscles are not in balance, which muscles are contracting at the wrong time during the gait phase, and which muscles have lack of selective control, which means that when you go to move those muscles, you have difficulty coordinating those movements. Which muscles are weaker? Are there fixed muscle contractors? And we can tell that by moving limbs through a range of motion and sensing how much resistance we get to stretch and what it feels like when we get to the end of the range of motion. What your coordination is like, and whether there's pain. That's part of this gait problem that you're coming to see the physician for. Second thing here is, doing the exercises, and what are some of the exercises that are usually recommended? This is pretty much the bedrock here, stretching and range of motion. And Dr. de la Tour demonstrated that to some of you in the audience on the first day at the conference, that stretching and holding a joint for as long as you can tolerate it is much better than trying to get as many stretches in a certain amount of time. So back and forth stretching is not nearly as effective as a stretch and hold. And if you want to know about how much time to hold, I don't really have a number, but I would say hold it as long as you feel comfortable doing it, probably 2 to 5 minutes, and preparing those muscles before you stretch them with some sort of local heat or local cold would be very beneficial too. The next thing on here is myofascial and joint mobilization. These are techniques that some therapists are trained in and very good at doing. And they're basically sophisticated massage therapy techniques that they've learned to loosen up some of the tightness in your muscles and in the soft tissues that are underlying the skin, in between the skin and the muscles. We talk about active, assistive, active, and resistive exercises. These are just 3 different kinds of exercise programs which will demand different amounts of efforts on the part of the patients, and the kind of exercise would be determined in conjunction with the therapist and your physician. Then the next type of exercise here is facilitating useful co-contraction, which basically means is looking at the muscles that you're using and using techniques to get ancillary or other muscles to contract that might give you more stability at the same time. And endurance and cardiovascular training are also important parts of an overall exercise program and prescription. And then making it relevant is the next part of what I think is an important thing to think about when you're putting together a exercise program or a gait training program. If it doesn't have a relevant meaning to you in your daily life, it's much less likely that you're going to do it. So functional training is really important. So this means having your physician talk to you or your therapist talk to you, find out what it is that is a barrier to you in doing the things that you want to do on a daily basis. And these are just some things that I listed that would be relevant. Self-care activities, moving around in the bed or going from the bed to the wheelchair, mobility training, coming to sit in terms of being able to sit with good balance and ease, and then transfer training. So these are some aspects of functional training that are useful. You'll have a chance to ask lots of questions about specific braces and orthotics tomorrow morning during our question and answer session. But what I'd like to do now is just show you some pictures of some of the devices that you're already using, and then at the end I'm going to show you a couple of new devices that we're just starting to use in our therapy program for individuals with spinal cord injury. The person that founded the Kennedy Krieger Institute was Dr. Phelps, and these braces are from Dr. Phelps's era, and pretty much are made of leather and shoestrings, and just support the ankles. And the principles are the same today as they were back then, that good ankle support is one of the key factors to a gait program, so that you're not collapsing during that initial phase of weight acceptance, because each step starts with putting down your foot and having a good base of support, so that you can then propel yourself forward with the next step. These are just listed some of these aids to therapy that we're going to take a quick look at. These are pretty much what standard ankle-foot orthoses now look like, and there's a company in Washington called Cascade that came out with what they call dynamic ankle-foot orthoses, or DAFOs, DAFOs, and it pretty much spurred a lot of new interest in, well, can we redesign these ankle braces in such a way that's more useful, practical? And I think one of the things that they came up with that seems to be different than the AFOs that we had prior to the Cascade kind of DAFOs was this part right here, which is a plastic that folds over the top of the foot and kind of holds the heel back down into this part of the DAFO. So this feature, this one small feature, which really you didn't see in the pre-DAFO era, I think was a small change in design, but it made a lot of sense, and someone started figuring it out that let's have this extra piece of plastic that wraps on the top, and then put the straps across that kind of seat the hindfoot or the heel well down in the DAFO, so you're not always popping up out of them, and that had been a problem earlier. The length of the DAFOs will depend on how much control you have at the ankles and around the knees. So this would be a supramalleolar or short DAFO. This one would be more your standard kind of ankle-foot orthosis, which goes up the knee. And then depending if you have control at the knee or the hips, you might add a piece to the DAFO that goes above the knee, or to combine it with some other bracing, and that might be called a KAF, or knee ankle foot orthosis. And this one over here has a joint built into the ankle, so this would be more of a DAFO that you would use if you had range of motion, so you could bend your ankle in past neutral in the dorsiflexion range, but you'd want to block it so that your toes aren't going to go down, and you end up being stuck walking on your toes. This is just a picture to show how the DAFO changes a gait pattern. This was obtained using a device called the Gait analysis, which is a computerized walkway. And sorry, keep hitting the wrong button. What this shows is the pattern of the foot as it steps on the walkway here. And without the AFO, this is the heel, and these are the toes and the metatarsal heads, which is the feet bones. It shows poor contact back in this area here without the DAFO on the left side. And when the individual uses a left DAFO, it changes the pattern quite a bit. So there is evidence that you can change the gait mechanics using these braces, and people are much more stable in them. Standard walkers, anterior, posterior walkers, I don't need to tell you about them. They're usually an aid to walking. And this is something that we use in kids called a gait trainer. And it's sort of like a walker with extra straps built in and extra pads. So this would be for someone who has less control of the legs but still wants to get around. And they're on wheels, and they can be customized, and different straps and pads added depending on how much support is needed. And these come in small, medium, and large sizes too, so they're not just for kids. This is a variation on that, which is a wheeled prone stander. So if an individual wants to be standing and doing some things standing, but also wants to be able to move around, you could think about trying out one of these mobile standing devices. There's a lot of interest recently on weight-supported therapy over a treadmill. And we're doing this more and more in our therapy gym. And the device, again, is set up so it can be customized to the patient's weight and the patient's body type with different slings. And then this apparatus is moved over a treadmill. So here's a picture of the weight-supported device over a treadmill. And there is research coming out now that suggests that using this combination of weight support and treadmill apparatus can significantly change gait parameters, especially in children. So this is from an article from our journal, the Archives of Physical Medicine and Rehabilitation, where 3 months of treadmill training, 3 times a week, 25 minutes per session, resulted in clinically relevant improvements in 6 out of 10 patients, and other motor mobilities in 8 out of 10. So research is now coming out suggesting that this is a good training method for people with spinal cord injuries and other forms of motor disabilities. This is one of the new devices that we have at Kennedy Creeder. It's called an Easy Stand Glider. And unfortunately, I couldn't take a picture of someone in this glider, so I'll have to try to show you how it works. This is a chair that the person sits in. And then there's a hydraulic lever that when you push it, you stand up. Now there's straps around her that hold you in place. And then this picture doesn't really do justice, but this is a foot plate here, and there's another foot plate in the back. And those foot plates work sort of like a Nordic tract. So by using your arms, you can get leg motion back and forth, and you're in a secure device as well. So we use this for aerobic training and also for motor pattern training in terms of moving the legs back and forth for individuals with spinal cord injury. That's called an Easy Stand Glider. And then there's a booth outside about these smart bikes. This is an RT1 300. And again, I couldn't take a picture of someone in it, but basically it is an electronic ergometer. We don't call it a bicycle because insurance doesn't want to pay for recreational devices like bikes. So it's not. It's an ergometer, and insurance will cover it for that. And this is the device that we use for pattern functional electrical stimulation. And what that means is we put electrodes on the quadriceps and hamstrings and other muscles, then and then they're programmed to contract at certain times in a cycling cycle. And the machine has a little output out here that will track how much effort is being required to push the pedals forward. The idea is to gradually decrease the amount of of strength that the bicycle is putting into making one cycle and then transferring that over to the individual who's actually activating the bike. If the rotations fall below a certain number of cycles per second, then the bike starts to do more work. If you're going faster, the bicycle senses that, or the ergometer senses that, and then it cuts back on the amount of work it's doing so that you're doing more of the work. So it requires some fine-tuning. It requires it requires that the therapist gets a good sense of what you're capable of doing, and then it can be set up to be a exercise device for an individual patient, depending on what their needs are. Okay, so that was a quick summary of some of the things that we're thinking about these days with respect to gait analysis and a variety of equipment that we use for exercising individuals with spinal cord injuries. I'd be happy to answer some more questions now or later on. Thank you.